Cheers. One of the reasons for coming to La Crosse is the Mississippi River. And in 2014, along with a young lady friend of mine, not my wife, just a friend, I took it into my head that I wanted to kayak the entire length of the Mississippi River. So we did.
Which way?
Now, I don't need to tell you guys that it's a big river. Now, it carries with it one or two problems. But there are people up and down that river who are tremendously helpful. And one of them is a guest of mine here today. It's a man called John Sullivan. John Sullivan started an outfit called the Mississippi River Paddlers, which is a Facebook page, which then grew into the River Angels. And the River Angels are people who are up and down the entire length of the river and will offer assistance and help to everybody and anybody that needs it. I needed it. My friend Grace and I got caught in quite a bad storm on Lake Pepin and had to end up holed up in the lovely town of Lake City, who invented water skiing. John came up and rescued us, which has happened as well because Grace had suffered some terrible sunburn as well. She had second-degree burns and blisters all over her shoulders, so he found medication for us and literally saved our lives. I think that's about the best way of putting it. And John is a very modest man and probably won't like what I'm about to do, but many of you people here will know today about Paul Harris. And the fact that when Paul Harris died, everybody said, what are we going to do to commemorate him? And we created the Paul Harris Fellowship. So from my personal giving, I'd like to reward John Sullivan with the Paul Harris Fellowship. So, Mr. President, fellow members, John represents a lot of people, most of America, so he is a very worthy recipient, and thank you ever so much for affording me the opportunity. Thank you very much indeed.
That's a great story about citizens of La Crosse. Okay, introducing today's program is David Settler.
Thank you, Roger. Last week we learned the personal story of Steve Rumler, who died in 2011 after becoming addicted to prescription painkillers. Unfortunately, his story is all too common. I'm sure there are probably even people in this room who know of similar stories. In fact, in a typical day, 78 Americans, almost probably a little more than half the number of people in this room, die as a result of opioid overdoses. Today we're joined by two local experts on this epidemic. Dr. David Onsrud is a family physician with the Mayo Clinic Health System Franciscan Healthcare. He's board certified as a family physician and also by the American Board of Addictive Medicine, and he's the local addiction specialist for Mayo. Dr. William Bucknam is an addiction psychiatrist with Gunson Health System. He's board certified in both addictions and psychiatry. We're just going to speak for a few minutes about this public health crisis, and then we'll take your questions. So please welcome Dr. Onsrud and Dr. Bucknam.
December 12th, 1982, 4 o'clock in the morning. Ring, ring. Hello? Bill, it's your brother, Dawn. Jack and Lois were killed last evening. I'm Bill. My then 35-year-old sister and her husband Jack. was struck by a drunk driver that crossed the midline while shopping, Christmas shopping, for boys 742. I'm in my third year of psychiatric training, and I realized instantly I did not know what I wanted and needed to know about not only drunk driving, but addiction. I've heard about it. There's a lecture or two here and there. But, and I have to say it's sad, it's still true that medical education falls way short of the need for physicians to understand what it is they're dealing with when they deal with their population that has addiction. And once you recognize addiction, you begin to see it all sorts of places. It's a really huge problem, as the video from last week touched on. It can no longer be entertained by any reasonable person that the disease of addiction is anything other than just that, a disease, in the same sense of any other medical illness. This is not a moral failing. Addiction is not weakness of character. Yeah, there is an element of choice with the first drug use, but if there is a genetic predisposition and a biological substrate for the development of addiction that is inherited, and often, that individual may progress over varying periods of time, sometimes months, sometimes decades, to manifest the phenomena of addiction disease. If we use the framework of just alcohol, but it applies to any other substance addiction, it's continuous use, despite negative consequences, with loss of control. Loss of control, what's that? Well, that's going to the bar thinking you're going to have a couple of drinks with your buddies after work, and you end up closing the bar, and it's 12 beers, 30 beers later, and you're stumbling home and you get a DUI. And you keep doing it multiple times. And you lose jobs, and you crash cars, and your marriage falls apart, and you keep doing it. It's really kind of insanity. There's nothing else we do that with that kind of repetition and those kind of dire consequences and think, well, I'm fine. I don't have a problem. I'll quit tomorrow. I don't need any treatment. This is the kind of delusion that goes on in the minds of folks ill with addiction disease. They are the last to know that they are so afflicted. Everyone else knows. Their family is doing all the emotional work and doing all the hurt and all the suffering while they're just lightly drinking away or drugging away or whatever they're choosing to do. Our science has progressed now to the point where we do have very strong evidence, irrefutable evidence, that this is a brain disease, and we have treatments for certain kinds of addiction. Not all the drugs of addiction that we have treatments for, but we certainly have robust evidence for the treatment with medications, at least, and other things, of alcohol, sedative hypnotics, and opioids. Multiple medications can be involved in the use of these medications, and to not practice in a medication-assisted treatment program, I would suggest to the audience is short of not doing your bound duty by that person. I'll even go so far as to say that it could be considered malpractice in the world of medicine. If we have an available medication treatment for this particular illness and not to offer it, and say, well, just pull up your bootstraps and there's an AA meeting around the corner, make sure you're there. Now, I'm not knocking AA by any means. AA is very, very, very valuable. And it saved many a person with addiction disease. Notice I avoid the word addict because that's pejorative. And these people are already feeling miserable about themselves. So I do my best to not add the weight of another pejorative term, addict, although they use it in reference to themselves. I can't change that, but I will do whatever I can to treat them as they are fellow human beings who happen to have an illness in which their powers of better judgment, reason, impulse control are hijacked by the force of the unconscious addiction center in the brain. The person doesn't grow up saying, well, I want to become an addict. No. They have changes, brain changes, and this is measurable by MRI studies and whatever you want to look at. There's no ifs, ands, or buts about it. This is fact, that there are brain changes in the brain of a person with addiction disease, such that the impulse to use the drug hijacks their powers of reasoning and better judgment. And they continue to do the same thing over and over and over, just as I talked about loss of control. Continuous use despite negative consequences, with loss of control of the 3 C's. Handy little thing you can put in your pocket, and when you recognize that, oh, there's an addiction problem there. And it doesn't necessarily have to be to a substance. This can occur to behaviors as well. We hear all the time about internet addiction or pornography addiction. Sexual addiction is out there. Food addiction. And all these things that the science is not to the point where, aside from gambling, it's recognizable in a diagnostic manual in psychiatry, but we're working on it. So, I'll turn it over to Dr. Onser at this point.
Well, thank you all, first of all, for being here. I see a lot of friendly faces out there. Appreciate you folks taking the time to listen to us and hear our spiel. Dr. Bucknam and I got together and decided how we were going to do this. He was going to talk mostly about the disease of addiction. It is a brain disease. I was going to talk more about doctors and prescribing habits and our part of the problem. Because in family medicine, unfortunately, I get stuck dealing with a lot of people with chronic pain complaints. Legitimate chronic pain complaints that's reduced their quality of life to nothing. And very similar to that video, I hope most of you saw that video last week, very similar to the video with Steve Rumler. These folks come into my office, they've got failed back surgery, failed neck surgery, they've got neuropathies, they've got any number of chronic pain issues. They're young, 40s, 50s, 60s, I consider young these days. And they have a lot of life ahead of them, but their quality of life has been pretty much destroyed by their pain. Their uncontrolled pain. They've tried everything. They've tried physical therapy, occupational therapy, injections, acupuncture, massage, all non-narcotic medications, anti-inflammatories, muscle relaxants, antidepressants, anti-seizure meds. You can just list, there's 12 to 14 things out there we tried. They've tried them all. Nothing's worked. Somebody finally pulls the trigger, says, I'm going to try out some low-dose opiates. Boom. Just like Steve Rumler. Their life gets better. They can function. They come back and they say, thank you so much. For the first time in 10 years, I can go to my kid's ball game. I can do this. I can do that. And you've made their life better. You've also let the dragon out. And that's the crux of the matter. And our science is not good enough to tell us who is going to continue to benefit from that medicine and who, like Steve Rumler, is going to lose control. We just don't know. Let me back up. I'm the medical director for the addiction services at Mayo, our residential and outpatient treatment programs. I'm also a family physician. I've been there for over 30 years. I actually am from this area. I grew up in West Salem, graduated from West Salem High School. I went to Carroll College in Waukesha, med school in Iowa, an internship in Youngstown, Ohio, and a residency in Milwaukee. Then I traveled for a year as a doc to Arkansas, Alabama, Kentucky, Colorado, before I finally settled back in La Crosse in 1985 and joined what was then Skemp Clinic. I say all that because I want to impress upon you that there is no place like La Crosse for drinking and alcohol abuse. It's just unbelievable. None of those places I lived in treat drinking in their culture like they do here. Not even Milwaukee. Alcohol and opiates share the same receptor in the brain. They both share the mu-opiate receptors. So a place that's got a high prevalence of alcohol abuse is going to have a high prevalence of opiate abuse. It's biology, people. I just want you to realize that in this area. National definition of alcohol abuse is for men, more than 14 drinks in a week or more than 5 drinks in one setting. For women, more than 7 drinks in a week or more than 4 drinks in one setting. I can see a lot of you doing the math. I don't want to hear any more from this guy. A drink is an ounce of alcohol, 4 ounces of wine, or 12 ounces of beer. So you can do the math. If you free pour a couple shots and have 3 of those, you hit the alcohol abuse amount. So that is something we need to keep in mind in this area. A little bit about pain pill prescriptions. Back in 1990, prior to that, when I trained in the 80s, we didn't use narcotics for chronic pain control. We just let these people suffer. Around there, we used narcotics for post-op pain control. Somebody broke their bone, something like that, give it to them for a few days, and that's it. Around 1990 or a little after, some organizations said we are not treating pain adequately. We are cheating these people out of appropriate treatment. These people need treatment for their quality of life. And the pendulum, of course, swung all the way the other way for the next 20 years. We started treating all these chronic pain folks with opiates. It was our duty. They introduced pain as a 5th vital sign, right along with your blood pressure, your pulse, your temperature, and your pain rating. So docs were under pressure to start prescribing meds. So our companies came out with some great pain medicines. OxyContin, as most of you have probably heard of, came out with a, quote, totally safe narcotic for pain medication. As we know, that's certainly not true. But it was marketed that way, so pharmaceutical companies jumped into the fray, and doctors started prescribing. Now 20 years later, over 20 years later, we've learned that we've done a lot of damage, and the pendulum's going to swing right on back. As human beings, the pendulum doesn't stay in the middle very much. We go from one extreme to the other. So now everybody's saying don't use opiates, be very careful, we're part of the problem. These people using opiates on the street are the ones getting hooked on heroin and they can't get their opiates anymore. And there is some truth to that, there's no doubt about it. So at Mayo, I'm part of a small group. We're going around to all of our satellites and all of our departments and trying to educate the docs on what we consider the safest way to prescribe opiates. There is no totally safe way to do this. You can either say no, let the person suffer, and a lot of my partners have done so. I think that's, not right. I think it's their duty to treat pain and suffering, and because opiates have such a bad name and are so risky and dangerous and challenging and scary, they just say, I'm not going to do it. So those of us that do it end up getting a disproportionate number of people that come in for pain complaints. What we're doing is we're trying to educate them on seeing these people more often, doing urine drug screens, checking the prescription drug monitoring program, which is a statewide pharmacy program, so I can see where they filled scripts when and how. And just basically trying to do some basic safe things to keep these people from doing what happened to Steve Romer or Prince and prescribing more and more pain meds to the point where they cross the line into addiction, start using pain meds from other sources, and ultimately accidentally overdose. So that's where we're at. David said you guys are here because you want to help. He said that you guys would have lots of questions about how to help, and I know that's why you're here. And I thought about that. I was like, well, how can they help? Obviously, the first thing is you can support our local resources. Cooley Council on Addiction is a wonderful non-for-profit addiction center right on West Avenue across from Walgreens and across from our place. Cheryl Hancock is our executive director. She's out here somewhere. And so let's say everybody's name now. Steve, Joe. Oh, all right. Anyway, you can support places like that. Sometimes I'm on the board. Sometimes we struggle financially just to keep the doors open. It's a wonderful thing. You can support your employees, your loved ones, whoever is struggling with addiction. I think the most important thing and the hardest thing that you folks can do is to change your mindset. When you think of an addict or an alcoholic, I'm sure a lot of you think about the down and out person, the person under the bridge, the addict with a bunch of tattoos, shooting up heroin in and out of prison. That's the stereotype most people have. When you think of an addict, I'd rather have you think about people like William Cole Moyers, the guy on the video that introduced the video, Dr. Marv Sapala, He was the director of Hazleton that was on the video. He was also in recovery. I'd like to think about people like me. I'm an alcoholic and I'm a drug addict. I haven't touched a pill or a drink in well over a decade, but I still have the disease. It's right up here in my brain. Just like Dr. Bucknam said, it's a brain disease, it's always there. It always will be. I'm one drink or one drug away from being Steve Rumler. And by the grace of God and by the support of my employer, Mayo Franciscan, through my multiple treatments, I'm still here talking to you and Steve Rumler's not. I can't tell you why. All I can tell you is that when you think of alcohol and addiction, try and put my face or William Cope Myers' face on it. Don't think of that down and out guy in the gutter. This is a brain disease that can affect anyone, anywhere, anytime. I have no doubt there's several people in this room that are either affected or in recovery. 1 in 10, it's estimated. And I just want you to take that home with you. And that's all I had. Thank you very much.
Can you take questions up here? Both of them. Yeah, Dr. Austin. Sure. Any questions?
My time's up.
I have a question about the use of medical marijuana. I know it's not approved here, but what's your experience with it in the states that have approved it?
I came from Michigan 6 years ago where it was approved, but had only been approved for a little less than 2 years. So I had very limited personal experience in my practice at the time. I think it's a misnomer to use the phrase medical marijuana because we don't know enough about it. I'm relatively convinced that there are medicinal applications of some of the substances that are found in the marijuana plant, but there's 1,000 of them. And we don't really know which ones are doing what. And to call this medical is to imply that it has gone through all of the rigorous studies that any substance that we call a medication must go through in order to be approved by a federal drug with the FDA. And marijuana has been classified as in the same category as LSD and heroin and cocaine. Cocaine, there are some medicinal applications too, but that's beside the point. And so it, by definition, cannot be studied until the federal government takes it out of that category and the FDA says, okay, we'll honor this grant and we can begin a study of marijuana. I personally would like to see that happen so that we can apply some reason and attempt at doing science instead of just doing a response to a populist movement and responding to legal changes and popular votes and calling it medical when it has no reason to be so described. It is a substance. It probably has some help for some people. I'm sure of it. My patients tell me that all the time, and they want to argue with me. Well, okay, fine. You're welcome to use your marijuana, but if you're wanting to do your recovery program, because we also know, beyond a shadow of a doubt, that there is addiction associated with marijuana, you might have to go elsewhere because I want you fully engaged in recovery, and you can't be doing that when you're smoking dope.
Thank you.
I think just to add to that real quick, I was at a conference in San Francisco about 4 or 5 years ago where there was a full day on cannabinoid research. It's fascinating. Our cannabinoid receptors are everywhere. Central nervous system, peripheral nervous system, everywhere. There's no doubt there's certain cannabinoids that have definite medical benefit. Seizures in kids, depression, anxiety, pain, bone healing. There's no question. The problem, as Dr. Bucknam said, is we haven't been able to study that stuff. Marijuana's got about 240 active ingredients in it. THC is one of them. That's the addicting component. So for people with a history of addiction, I treat it the same as alcohol. I don't care if it's legal or not. You got to stay away from it if you want to be in recovery. For people without a history of addiction, there's no doubt some medical benefit.
I just, I've seen several things on TV and newspaper that some doctors even have not recommended, but suggested that red wine, up to 2 glasses a day, per day, is good for you. So that seems to be a contradiction of what you said.
Look at him. Just look at him.
It doesn't do anything for your waistline.
You know, my doc said the same thing to me, and that's fine with me. I don't happen to have the disease of addiction. I didn't necessarily qualify. It's not on my curriculum vitae as a qualification to be up here talking to you, but it is for David. It doesn't matter. If you don't have addiction disease, yeah, you can safely drink a glass or two of wine. It falls way short of what David described as the definition of abuse. But if you do have addiction disease, it's like dancing with the devil. It's like picking up something with a bullet and you're going to pull the trigger. Because you never know when you're going to stop. Your brain gets hijacked, that's how it works.
Dr. Schultz.
David, suppose any of us get to their doctor's office and they're offered an opioid for pain relief. What kinds of questions should we ask? What kind of discussion should there be to make sure we're using appropriately the right length of time?
Well, that's good. That's a real good question, and that's the complicated part of this, and that's what we're trying to standardize and formalize somewhat with some of these guidelines that we're forming. They have an opiate risk tool where we have 7 or 8 things we look at to see how risky it would be for this person to lose control. We monitor them closely, but everybody's different. I mean, you can't tell by looking at somebody you're going to be an addict and you're not, so I'm going to give you pain medicine, but it's too dangerous. It's just impossible to do that, so you just have to do the best you can. If it seems like it's something that's important and indicated for that patient, you start out slow, you go very carefully, you watch them very closely, and you cross your hands and tighten your butt.
To continue on that then, I've been taking my father to Gunnison for a number of reasons the past couple of months, and they'll always ask on a pain scale of 1 to 10, where's he at? And they'll say 2 or 3, his knees today are a 3. Where does he have, what number does he have to give before that conversation you just talked about begins? Does his dad say he's a 6, and then all of a sudden we're talking, oh, maybe Oxy is there for an Elmer? Does he need to say 7 when we have that, and he's walking to the pharmacy next? When you've got your scale, when do you start acting? And what is the action you take?
What I think is appropriate is to apply the measure of function, not just the subjective measure of pain. If his function is impaired, and pain is impairing his function, then it warrants attention with medication.
We measure function as one of our primary endpoints versus pain. We do function questionnaires, and we're like, are you able to walk to the mailbox now when you weren't able to before? How much is your bad knees limiting your life? Can you get up and move around? Do you need help? Can you do the things you enjoy doing in life? It's all a quality of life and function issue. We're not going to get rid of the pain, even with the best pain meds out there, unless we knock them out cold. So we're not going to get rid of the pain, and that's not the goal. The goal is to reduce the pain to the point where their quality of life improves. And that's very subjective. So the number is just one piece of the puzzle.
David? Most of you know I'm an oral surgeon.
You listen to your wife, too, I see.
Smart man.
In fact, a lot of what we do has been used as a model for pain and the types of medications. And I think people have to understand acute pain versus chronic pain. You've been talking about chronic pain. I have a lot of patients and parents say, I don't want my child to have, hydrocodone or a narcotic because they're worried about the addiction. I think we have to realize that for most of us, and dentistry has gone from number 3 to number 5 as far as the prescriber of opiates because of our education, just like you're working with your people. We want to have people take their pain medications for pain to get relief. We use long-acting local anesthetics. Most of the time, I've got prescriptions that are going to last 3 days, and we get patients through that acute pain time. And I always tell them, if you're done with it and you've used them, because some people don't use any and some people will use them all, to get rid of them. And we've got drop-off places at the police stations where they can drop off those And I think it's important that those don't get out into circulation. And that's the thing. But there is a difference between acute pain and chronic pain for prescriptions.
And that's a good point. We do try and educate people on something new that we haven't been doing about what to do with their pain pills, because you just give them the script and send them on their way, either short-term or long-term. And we have to tell them, number one, keep them locked up. Number two, don't share them. People don't think about this. They're like, well, I'm going to give so-and-so a pain pill because they're in pain. I remind them, that's a felony. It is a felony to share a controlled substance with someone else. And to dispose of them properly, which is a hassle because the drop boxes aren't real readily available. They have those a couple days a month or whatever. The DEA still says flush them. The environmentalists don't like that. But the DEA still says that you can flush them down the toilet. They've got these new little kits now that have activated charcoal that you can buy for $3 at the pharmacy, and you dump your pills in that. Punch it, the activated charcoal deactivates the medication. There's some question about that. When they get in the landfill, they think the medication's still going to leach out and get into the groundwater, and then you got all the extra charcoal, so you haven't accomplished a thing. So getting rid of those pills, though, is very important, like Dr. Durkee said. The CDC weighed in recently. You may have seen the news stuff on that. They never tell doctors how to practice medicine. This is the first time they've weighed in because of this crisis and gave these guidelines. One of them is to never give more than 3 days of narcotics for acute pain, just like Dr. Durkee said. So,
And also, could I just dovetail on that? The vast majority of young people that start in with a career using pain pills do so from the family medicine cabinet. They're not going to the street. The vast majority are doing so from the family medicine cabinet. So it's very important to get rid of unused medicines.
Can we ask you guys to stay around after the meeting, and then we can have more questions after that?
Oh, sure.
So you, okay. Thank you. And responding for the club is Dean Dickinson. That's why we had to cut it short.
Well, at the outset, I want to make this observation. I want to thank a friend of mine, Sandy Schley, who was president of the Rotary Club of Edina, Minnesota, who felt the pain of Bill and Judy Rumler when they lost their son, and took it upon herself to create that tremendous video that we had last week. There are people in this room that are far more capable and qualified to respond at a technical level to the program last week and this. I can only respond at a personal level. It moved me beyond Elvis and Michael Jackson and Prince. It became a very personal thing with me. When I saw the pain and suffering that were imposed upon Bill and Judy Rumler with the death of their son. Steve Rumler could have been my kid. Could have been your kid. And considering the demographics of this club, it could have been your grandchildren that were involved in opiate drug addiction, pain reduction. I don't know where we go from here. I'd like to think that we've begun to move beyond awareness to an extended conversation about what it is that we as Rotarians and this Rotary Club could possibly do to assist in raising the level of awareness in our community and to move from awareness to action. 28,000 people die each year in the United States. That absolutely dwarfs what was happening in the 1950s with regard to polio addiction, or polio problem. And we did not deal with the symptoms, we went to the root cause. And I think if nothing else comes out of this, maybe we can move from being aware to being activists. Thank you very much, and thank you to the doctors for coming today and sharing your expertise with us. We really appreciate it.